today we have the privilege of having Dr. Shaun Goodman, and Professor Goodman is one of our colleagues in our division, and he also has lots of other appointments, as you can see on his slides, in UHN, in CHRC, Canadian VIGOUR, as well as University of Alberta. So we just love having him actually with us, and he's kindly to offer to review the ESC meeting that was in Madrid towards the end of August and beginning of September. And in case you haven't gone, and now is the time to review them. So without further ado, let's have Dr. Goodman. And also just one word that we're trying to send out a survey that you may be getting as well regarding our round, because we're in the process of trying to reinvigorate the round for St. Michael's Hospital Division of Cardiology. And we just want to find like the timing, the formats, and content. So your feedback will be very useful. We'll be getting this out in the next couple of weeks. So we look forward to hearing back from you. And without further ado, let's pass it on to Shaun. Please go ahead.
Thanks, Shiming, and for the kind invitation and the opportunity to share some of the highlights. There were many. It was a pretty packed ESC Congress this past August, early September in Madrid. And I'm only going to be able to touch on a few topics, but hopefully this will be of clinical relevance to the participants. So the way that I'm going to do this is I will go through a series of studies on different areas of interest. And so rather than the traditional present for 45 minutes and then save up the questions and discussion till the end, I'll break it up into segments and give people an opportunity. Please use the chat function. For those who present on Zoom, you know that I can't see any of you and I can't see hands or things in the Q&A. So please do that as I go along, and then I'll stop after each segment and happy to address any comments or questions. These are my disclosures. I work with many of the different companies, most of it's research grant support, but I also personally receive some speaker consulting honorarium. So as always, take what the speaker has to say with a grain of salt. All the details of the relationships I have with industry are listed at the Canadian VIGOUR Centre cvc.ca website. So the objectives for today, I want to review some key presentations from the ESC Congress, and more importantly, discuss what are the implications for the management of our patients who have atherosclerotic cardiovascular disease, with a focus on those with coronary artery disease, including post-myocardial infarction. We'll touch on a little bit of heart failure and also atrial fibrillation, and hopefully those implications as they relate to your clinical practice, again, will be of value to you. So the first study, which was literally the first late-breaking study that was presented at the ESC, wins the prize for the neat name. So this is related to potassium. So it's called the POTCAST study, a randomized controlled trial of arrhythmia prevention using targeted plasma potassium levels in implantable cardiodefibrillator ICD patients. Here's the background. We're well aware as clinicians of the U-shaped risk associated with not only hyperkalemia, but also hypokalemia, in particular as it relates to cardiovascular and or arrhythmic events. But what about within the so-called normal range, between 3.5 and 5? Is there also some relationship, at least schematically as diagrammed here, there is theoretically a relationship between risk, even within the so-called normal range? The average potassium level in cardiovascular patients is somewhere around 4 and change. But this study raised the question of if you actively increase those levels, let's say from the low 4 millimole per liter range into the 4.5 to 5 millimole per liter range, could that have some impact in a favorable way of lowering arrhythmic-related cardiac events? So the POTCAST trial was designed to assess the efficacy and also the safety of a treatment-induced increase in plasma potassium levels. They targeted the so-called high normal range of 4.5 to 5 millimoles per liter. They chose a patient population that were at high risk of cardiac arrhythmias, including those who specifically were implanted, who had an ICD implanted. This was based on either primary or secondary prevention. This was an investigator-initiated study, a randomized open-label superiority study done they recruited patients out of 3 ICD centers in the country of Denmark. They screened about 1,500 patients to identify and randomize 1,200 patients that were allocated to either the standard of care versus the potassium uptitration in addition to standard of care approach, where they closely follow these patients. It says every 6 months on this slide, but as I'll show you in a subsequent slide, these individuals were in the earlier stages followed up every 2 weeks and getting their potassium levels and other assessments until they reached a sort of steady state towards the target, and then were followed up on an every 6-month basis. The patient inclusion criteria is in the bottom left here, and you can see these are individuals whose potassium level started out at 4.3 millimoles per liter or below. They had to be adults, and they had to have an ICD implanted. These are some of the baseline characteristics. They're evenly distributed between the 600 patients in the control group and the 600 patients in the aiming for the high normal potassium interventional based group. You can see that 56% of these patients had their ICD for secondary prevention. And you can see that the left ventricular ejection fraction, the median was 45%. And we see that there are patients here that might have other reasons to be on potassium modifying therapies, i.e. they have heart failure, and that was almost 2/3 of the patient population. The starting potassium at baseline was essentially 4 millimoles per liter. As I mentioned, there was an initial every 2-week assessment of potassium levels and other things, and there was an uptitration period that on average took about 90 days until they reached the levels that were aimed for, specifically in the high normal potassium in the intervention base group. So this included potassium-rich diet guidance, the initiation and or uptitration of dosing of MRAs, the addition or increase in the use of potassium supplements, and there was an attempt in those who were on potassium-losing diuretics to reduce those or to even stop them as part of the strategy, again, to get patients in the high normal potassium range in the 4.5 to 5 millimole per liter range. As you can see on the right-hand side, despite these attempts, there was not on average an achievement, at least for the average patient in the high normal potassium range. They landed around 4.3 millimoles per liter, but this was a statistically significant difference compared to the control group that was achieved fairly early on and maintained out to the approximate 5-year follow-up time frame. Over back on the left-hand side, I've highlighted how many people completed the drug adjustment process, 95%. And you can see that because some of them had heart failure, for example, they were already on MRAs at baseline, or at least 222 of the 600 patients were. There were almost 200 additional new starts, such that approximately 2/3 of the patients in the high normal potassium intervention group were on an MRA at the end of the trial. Potassium supplementation was already present in 131 patients out of 600 at baseline. There were 343 new starts, so that 474 of 600 patients were on potassium supplementation, just to give you some flavor for what the intervention group was added or increased. Here is the primary composite outcome. first occurrence of sustained VT as documented by the devices, or any appropriate ICD therapy based on VT, or any unplanned hospitalization that lasts for more than 24 hours related either to arrhythmia or heart failure, or death from any cause. And you can see that there was a significant increased risk for any of these time to first composite endpoints in those individuals who are in the control group. Overall, that was around 29% by 5 years' time, compared to in red, the high normal potassium group. They had fewer events, and by 5 years' time, the cumulative occurrence of one of the primary composite outcomes was 23%. When we look at the individual components, this is appropriate ICD therapy and/or detection of sustained VT, very consistent. And this was the primary driver of the time to the first primary composite outcome that was, again, lower risk, lower hazard ratio in those who are in the high normal potassium compared to the standard of care control group. Less difference, but again, statistically significant, and a hazard ratio in the same direction as the overall composite outcome as it related to hospitalizations for arrhythmia. Not so much of a difference, but very few in absolute terms for heart failure hospitalization. But again, I'll point out that while this isn't a statistically significant difference, the hazard ratio is in the same direction. And then finally, again, no significant difference for all-cause mortality, but only 75 deaths in total over 5 years' time. And the hazard ratio, again, in the right direction, i.e. favoring the high normal potassium compared to control group. I won't belabor the details here in the pre-specified subgroup analysis, but there was consistency of the benefit in the high normal potassium arm, regardless of age, sex, whether it was for the ICD had been implanted for primary or secondary reasons, etc., etc. From a safety perspective, there was a numeric increase in, for example, hospitalization, potentially related to the increase that was attempted in potassium levels. But overall, in absolute terms, this was quite small. So 17 hospitalizations in 17 patients in the high normal potassium group compared to 12 hospitalizations in 10 patients in the control group. So the hazard ratio, albeit not statistically significant, is almost twofold increase. But again, the important piece here is in absolute terms, this increase adverse events was small, and of course offset by the benefits that I've just shown you in the primary composite endpoint and the components of the primary composite endpoint. So this was published simultaneously in the New England Journal of Medicine, and these were the key take-homes from the investigator. The intervention increased potassium plasma levels by 0.3 millimoles per liter on average. That translated into a reduction in the primary composite outcome by a relative risk reduction of 24%. There were no significant differences in safety outcomes. There's a small price to pay in hospitalizations related to increasing individuals' potassium. But the net clinical benefit is clearly in favor of giving these patients with ICD some sort of potassium increase strategy. And this was pretty safe and obviously relatively inexpensive approach moving forward. There are some limitations, of course. This was focused only on an ICD population, mainly in European descent individuals in the country of Denmark, a single country and 3 centers. But I could argue that this is a good proof of concept for any patients who are at high risk for arrhythmias, not just those who have an ICD implanted. But for now, we can only translate these results clinically with great evidence in individuals who have an ICD. They understandably excluded patients whose eGFR was below 30. So we don't know in those end-stage renal disease and dialysis patients whether increasing potassium would be a safe thing to do. So those patients were excluded. We don't know about the adherence to the dietary recommendations to increase potassium intake. This was an open label study, although blinded central adjudication, and I would argue this is a pretty objective endpoint, which includes mortality and was mainly driven by appropriate ICD therapy for ventricular tachycardia or device-detected VT. So pretty hard to imagine, even though it was an open label approach, how that would be influenced from an endpoint perspective. Again, we don't really understand exactly where the biggest bang for the buck in increasing the potassium or the strategy by which that was undertaken is achieved. The different components were, sort of all of the above, including the guideline recommended use of MRA treatment one could think about in those patients who had heart failure. But again, this was a strategy-based trial and fairly cost-effective, one might imagine. So whether it's the dietary recommendations, it's the increase in MRA use and or the dose, it's the increase in the dose or the use of potassium supplements, whatever was necessary, that ultimately translated into a pretty clear clinical outcome benefit. So let me stop there. I'm actually going to stop sharing for a second here before we go on to the beta blocker discussion and see if anybody has any comments or questions related to the POTCAST trial and the role for increasing potassium levels, even in those who are in the so-called normal range, to try to target a 4.5 to 5 millimole potassium level to reduce significant clinical cardiovascular and arrhythmia-related events. Any comments or questions about POTCAST? All right, I don't see anything yet in the chat, or anybody want to take themselves off mute and shout out, comment, question?
Shaun, it's Kim.
Kim, fire away.
Yeah, very interesting. I guess the big question is the sort of practical implementation of these things in the real world is what we need to sort of understand. Who's following up, when are they following up, how do we activate the plan? Do they give any sort of insights on that?
It's
a particular geographical distribution which is different than I think the broader Canadian context with how we interact with primary care and so on.
Yeah, no, Kim, it's a great point. And we don't have much detail. I'm sure they'll do a formal cost effectiveness. And I have no doubt that this will be cost effective, but the cost, including of time and managing that you're alluding to, like who's going to be responsible for this aspect, is obviously an open question and a challenge. One could imagine that 2/3 of these patients are probably part of heart function clinics, which we know in the hands of nurse practitioners and nurses with guidance and oversight, but not necessarily the physician themselves, even though they might be the ordering physician for the potassium level 2 weeks from now. They aren't necessarily with algorithms in place. They aren't necessarily the one who has to call up the patient or affect that change. So I can imagine that in the right setting, this is something that could be affected in a way where the physicians don't need to be the ones who are primarily making some of these changes, including up titration of MRAs, for example, or adding potassium supplements. So not to sweep under the carpet your important question, but I think that this is something that with some of the infrastructures that we have in place is doable. But it's an important point. Absolutely. Great. Thanks. All right. While we're thinking more about potassium supplementation and implementation, let's talk about beta blockers. So I think I shared this slide at one of the previous rounds. Death, taxes, and beta blockers, are they all still inevitable? This raises the question about whether we continue to need beta blockers post-myocardial infarction. We know from some of the earliest randomized clinical trials post-myocardial infarction that there is a life-saving benefit and also so reduction in MI from beta blockers like timolol, for example, from the original Norwegian multi-center study group published in 1981, and other studies. There was a meta-analysis, or several meta-analyses, this is just one representative one, in the so-called reperfusion era that suggested that maybe beta blockers on top of reperfusion therapy and all the other secondary prevention therapies that we have in a more contemporary fashion might not lead to reduction in all-cause mortality. There are a bunch of observational studies, including from Dennis Coe and colleagues in Ontario, but also around the world, with divergent conclusions around whether those who continued on beta blocker therapy versus had their beta blockers withdrawn or maybe never even initiated post-MI, whether they do better, whether they do worse in a more contemporary era. And then in the early 2020s, we have a formal analysis that really said we need randomized clinical trials in a contemporary fashion in this particular patient population, particularly those who sustain a smaller amount of damage from myocardial infarction, those who have a so-called preserved left ventricular ejection fraction, defined variably. And then I shared this from ACC 2024, the REDUCE AMI study of 5,000 patients showed no difference in the primary outcome of death or reinfarction, or in a secondary outcome of anginal symptoms after 1 year therapy, i.e. those patients who had been revascularized and had come in with an acute myocardial infarction, they were randomized to receive beta blocker versus not receive a beta blocker. Now, importantly, these individuals had a truly preserved ejection fraction defined as 50% or more. Then in 3,700 patients, the French investigators presented the ABYSS study. Now, this is remote from myocardial infarction. They excluded patients who had had an MI within the previous 6 months. And in fact, the median time was 3 years from the time of the MI to the time of randomization in these individuals. So it became, or it was, much more of a beta blocker withdrawal versus a continuation of beta blocker study compared to the REDUCE AMI study, which was start on a beta blocker early post-MI versus not. And they were not able to demonstrate non-inferiority, so not non-inferior. And in fact, beta blocker withdrawal in this case was associated with a non-statistically significant, but 2.8% absolute higher rate of death, reinfarction, stroke, or rehospitalization for heart failure. So sort of contrasted with the REDUCE AMI study, but a slightly different patient population at a different time. So I'll remind everybody that a lack of evidence of a difference, non-significant p-values in both of these trials, is not the same as evidence of a lack of a difference. And the failure to detect a difference doesn't necessarily prove so-called non-inferiority, in this case of maintaining versus taking away or initiating beta blocker therapy. And so the conclusion, when I last presented to this group from the highlights in 2024 of the ACC meeting and then the ESC meeting, was we need more data, and there were a whole bunch of trials coming. And the exciting thing is that Reboot, Baytami, and Danblock, in some cases, they put the forces together, as I'll show you, and all of these trials reported out at the ESC 2025. So the first study is the Reboot CNIC investigators looking at beta blockers after MI in those without a reduced ejection fraction. This was a joint effort between the Italians and the Spaniards. So 2 different coordinating centers, but 109 enrolling hospitals across these 2 regions. Again, an investigator-initiated study, a pragmatic approach. These individuals were randomized at the time of discharge to beta blocker or no beta blocker. The type of beta blocker, the dose of beta blocker, was decided in an open label fashion by the managing physician. They estimated that they would need 8,500 patients to potentially demonstrate the superiority of beta blockers compared to no beta blockers. And oops, let me get my slide advance going here. They included both STEMI and non-STEMI patients. They defined not having a reduced ejection fraction as those individuals whose EF, by routine clinical management echo assessment, they had no central core lab evaluation, as being 41% or above. They did mandate that included patients had to have undergone invasive management. And what this meant is that all the patients at least had to undergo coronary angiography, whether they did or did not undergo PCI. As I'll show you, the vast majority underwent revascularization with a PCI and a small percentage of patients with CABG. These are the patient characteristics, similarly distributed between the two treatment groups. I just want to highlight a couple of things. 1 in 5 were women. Only 12% had an ejection fraction below 50%. So the majority of these patients, even though they were eligible if they were 41% and above, the vast majority of these patients had an EF that was 50% and above. About a 50-50 mix between STEMI and non-STEMI. And as I mentioned earlier, 94% of these individuals underwent PCI as part of their invasive management for their acute and in the early peri-MI arena. So the beta blocker use listed here, the different types of beta blockers, both cardioselective and non-selective, but the vast majority in Spain and Italy of these patients received bisoprolol. They were well managed with other medical therapy. You can see the utilization of DAPT, statin, ACE, and or ARB therapy. So here's the primary outcome, which was a time to first death from any cause, reinfarction, or hospitalization for heart failure. And you can see that the curves are superimposed on one another. There was absolutely no difference between the beta blocker in blue event rate and the no beta blocker group in gray, with a median follow-up of 3.7 years and an excellent low loss to follow-up rate of under 1%. This is drawn from the simultaneous publication in the New England Journal of Medicine table. Apart from the top line here, can't seem to get my mouse working here, which you can see the event rates. There were really no differences in all-cause mortality, reinfarction, hospitalization for heart failure. But I want to point out that the vast majority of these events, the majority of these events were death from any cause, and a minority of these were adjudicated as being from cardiac cause. So reinfarction occurred, almost 300 of them. There was no difference between the beta blocker and the no beta blocker arm. But this is going to contrast a little bit with the subsequent beta blocker trials that I'm going to present to you, where there were at least a greater proportion of deaths that were from cardiac causes. Now, we would not expect non-cardiovascular cause to be favorably influenced by beta blockers necessarily. So keep that in mind when we come to the other trials. In terms of crossover in this pragmatic open label study, when they looked, for example, 15 months plus or minus 3 months out from the randomization time period, there were about 8% of patients who were initially assigned to beta blockade that crossed over, so to speak, to the no beta blocker arm, i.e. They were not receiving beta blockers. It had been withdrawn for whatever reason. In contrast, in black, you can see those who were initially randomized to a no beta blocker strategy, 9% crossed over. In other words, they were prescribed beta blocker therapy, at least when it was looked at a snapshot time around 1 year post-randomization. To try to address the crossover that happens in an open label study like this pragmatic strategy trial, they did some per protocol analyses, including those who were on treatment, censoring patients out once they crossed over, for example, and they showed similar findings to the overall primary and secondary outcome findings, no differences in the outcomes in the beta blocker versus the no beta blocker arm. Now, to try to address the fact that there were a proportion of patients who were originally on beta blocker as part of routine clinical care, were included in the trial at the time of discharge. Half of them were randomized to come off or withdraw from beta blockers. And I mentioned earlier the ABYSS trial, remote from the acute MI, that was done by the French investigators. They actually showed potential harm of beta blocker withdrawal. So at least in this early beta blocker initiation or beta blocker even before patients came in with myocardial infarction, at least in the 3-month time window, there didn't appear to be any adverse outcomes. So no real rebound effect as it related to at least the primary outcome. And this was a secondary paper that they published simultaneously in Eurointervention. They also looked at the type of beta blocker. As I mentioned, not the majority was bisoprolol and some metoprolol, but there were other beta blockers, including less selective, beta-1 selective beta blockers that were used. And for what it's worth, in this post-hoc subgroup analysis, there did not appear to be any difference in the neutral outcome as it related to what type of beta blocker patients were using compared to no beta blockers. You won't be able to probably read the details here, but there was generally consistency on the primary outcome, whether you did or did not receive a beta blocker. However, they did show some numeric differences. For example, those who had a lower EF numerically seemed to have a better outcome with beta blockers compared to those whose ejection fraction was 50% or more, although the p-value for interaction was not significant. They actually showed a significant p-value for interaction for a type of MI. This is obviously only hypothesis generating in this subgroup analysis. This interpretation would suggest that STEMI patients were actually statistically significantly better off by not receiving a beta blocker compared to receiving a beta blocker. And then finally, they showed potential harm of not receiving a beta blocker in the women, in females, compared to males, where there was no difference. So I'm going to fast forward and show you some additional analyses that they performed and published on, but going to make the argument, be careful about interpreting or over-interpreting even significant p-values for interaction. I think these are all chance findings. Here is the sex difference paper that they simultaneously published. It does show, and this has been seen in the past, that women compared to men post-MI in a 5-year follow-up are at higher risk for adverse cardiovascular events. So that's consistent with what we know in the literature, although women tend to be older and have other comorbidities when they come into these trials. When you look at the right-hand panel, you can see that beta blockers appear to harm women, whereas for the primary outcome in males, there was no difference. Then they broke it down further into the EF 41 to 49% on the left-hand panels for women and men respectively, and then on the right-hand panels, those whose EF was 50% or above. And this is why I think this is a chance finding. Things are going in sort of non-biologic plausibility and different directions. So women did worse with beta blockers if their EF was 50% or more, but there was no difference between beta blocker and the control group, no beta blocker, in women whose EF was between 41 and 49%. In contrast, in men, in those above 50%, there was no difference, but in those below 50%, 41 to 49%, there was actually numerically a significant, non-significant benefit of beta blockers. So we've got things going in all kinds of different directions, and I think these are the vagaries, the downsides of overinterpreting multiple subgroups of subgroups. The take-home messages from the reboot group was that in those post-MI patients treated invasively, who had an ejection fraction of 41% or above, beta blocker therapy was not associated with a reduction in the composite of death, MI, or heart failure. There may be some benefit in those who have a mildly reduced EF, but this was inconclusive from the reboot subgroup analysis. And they go on to say that the apparent harm associated with beta blocker therapy in women who had an ejection fraction of 50% or above deserves further investigation. And as I mentioned, they published this simultaneously in the New England Journal of Medicine. So there's probably only a handful of you who remember some of these info commercials on TV late at night. But wait, there's more. And indeed, there is some more on the beta blocker story. So Dan Attar from Norway presented the combined BETAMI-DANBLOCK study. These were originally two separate studies that were combined together. Norway and Denmark combined forces. These are the two design papers that I've listed that were published earlier on. And then in 2023, 2024, given they were both having some troubles enrolling patients, given that there was a pandemic going on, given that the event rates were lower than anticipated, they decided that they would combine forces. They were obviously still blinded, but their blinded aggregate event rate was lower than anticipated. So they put the two studies in a pre-specified manner together. They're very similar in their eligibility criteria. You had to have an MI within the previous 14 days, an ejection fraction of 40% or more. And the BETAMI study, like the reboot study, leaned towards taking patients who specifically had undergone coronary revascularization as part of their index MI management. Here are the baseline characteristics, again, similarly distributed, a couple of years older than the reboot patient population. Again, about 1 in 5 are women, about a 50-50 split between Denmark and Norway. And you can see down at the very bottom, there are about 1 in 10 patients who are on beta blocker therapy prior to coming in to the hospital for their index MI and or prior to being randomized. In other words, some of them got started on beta blocker therapy in the early stages of their peri-MI management, index hospitalization. About 50% of these patients were ST segment elevation MI, and about 15% had an EF between 40 and 49%, that sort of lower range that I mentioned, around 11% in the reboot study. Most of these patients were revascularized, only 6% were receiving medical management. And at the bottom, you can see extremely well treated from a medical management perspective: dual antiplatelet therapy, antithrombotic therapy, RAS inhibition, lipid lowering, etc. Here is their primary outcome, which was all-cause mortality or major adverse cardiovascular events, and I'll define that in a second, but it's the usual myocardial infarction, ischemic stroke, etc. And in contrast to the reboot curves, here we see treatment with no beta blockers in blue was an inferior strategy to treatment with beta blockers in red, out to approximately 6 years time frame. The median follow-up, like the reboot study, was around 3.5 years. In contrast to the reboot study, maybe a slightly less beta-1 selective therapy, metoprolol was the vast majority of the beta blocker that was chosen in this particular case, and a median dose of 50 milligrams per day total. So pretty good adherence, particularly as noted in the first 6 months' time, and a 15% relative reduction in the primary composite outcome. This is listed here from the simultaneous publication in the New England Journal in their table. But here we can see that myocardial infarction was the sort of dominant endpoint that occurred, in contrast to all-cause mortality, only a minority of which in reboot was, as I mentioned, cardiovascular mortality. We don't have the details on the cause of death here, So take that with a grain of salt. But there was, even as an individual component, a significant reduction in myocardial infarction with beta blocker versus no beta blocker therapy. When did this benefit occur? Because this went out 3.5 to 5 to 6 years time frame. This is drawn from the supplementary appendix published in the New England Journal of Medicine. And in the first year's time, when they restrict the analysis to the primary outcome at this point in time, and also for the secondary outcome of myocardial infarction, for example, we can see that the curves split apart relatively early. And so the benefit does appear to be early on, which begs the question, as we come shortly to the end of the discussion, okay, probably beta blocker therapy should be continued, at least in those who have a slightly reduced ejection fraction, but do we need to continue this indefinitely? And that's an unanswered question. But at least within the first year's time, there is an early benefit of, in this patient population, giving a beta blocker compared to not receiving a beta blocker. The subgroup analysis, including in women, was consistent in contrast to the Reboot MI trial. There was also similar numeric benefit, whether you were a STEMI or a non-STEMI, in those who received beta blocker compared to no beta blocker. So these subgroup analyses contrast with the Reboot study, and again make the argument that this is what was seen in Reboot was likely just chance distraction, red herring findings. With respect to the EF, granted they're underpowered, there was overall consistency regardless of the ejection fraction, but there did appear to be in numeric, in absolute terms, a bigger bang for the buck. If the EF was between 40 and 49%, there was a 5% absolute risk reduction in the primary outcome, compared to if your EF was 50% or more, there was a benefit. In numeric terms, that absolute risk reduction was just under 2%. So it does appear that if you have a 40 to 49% ejection fraction, you'll get a bigger bang for your buck in terms of receiving beta blocker versus not. And these were their conclusions. And they published this Dan Block study in the New England Journal of Medicine. Now, the next presenter came up, Professor Rossello, and said he was going to, sort of tongue-in-cheek, he was going to put together, not only from a meta-analytic perspective, but from a what are the clinical implications and how do we reconcile that one trial, Reboot, was entirely neutral, and then the other combination of trials, Dan Block, was a positive trial in favor of beta blocker use. So what they did is they made the argument that in the ejection fraction between 40% and 49%, there was a suggestion that there may be a benefit in particular in that subgroup. And so they took the Reboot individual patient data, the BETAMI and the Dan Block individual patient data, and they grabbed 339 patients from the small capital randomized clinical trial. That was an 800 patient study done in Japan several years ago that showed similar outcome at 3 years' time amongst beta blockers versus no beta blocker individuals. So they took a small cohort of patients, individual patient level data, put them all together in this meta-analysis to address those who had an ejection fraction that was, in this case, 40 to 49%, depending on the trial. I'll remind you that the Reduce AMI study that showed no significant difference from our Swedish colleagues, they only included people with EFs 50% or more, whereas these other 4 trials included individuals that had 50% and above. That was the majority of the patients, but they had smaller subgroups, somewhere between about 10 to 16% of patients whose EF was between 40 and 49%. So they did a pre-specified, before they unblinded, they did a pre-specified analysis. And here is the primary outcome, looking at their composite of all-cause death, new myocardial infarction, which essentially means recurrent infarction. All these patients qualified by having an index myocardial infarction, or hospitalization for heart failure. So this subgroup is just under 2,000 patients. You can see the characteristics there, but there is a 25% relative reduction over a median follow-up of 3.5 to 4 years' time in those individuals in red who were randomized to beta blocker compared to those who were randomized to not receive a beta blocker in blue, the control group. This was consistent across the 4 trials, at least numerically, and there are different ways of doing meta-analytic approaches, adjusting, unadjusted, fixed effect model, but really all of them were consistent in showing about a 25% relative lowering of significant adverse cardiovascular events with beta blocker compared to not receiving a beta blocker. And this was also consistent for the individual outcomes that they put together as part of the primary composite endpoint that they had pre-specified. In other words, all-cause mortality driven mainly by reduction in cardiac mortality, myocardial, or in this case, myocardial reinfarction, or hospitalization for heart failure, all were numerically to the left of 1, although the 95% confidence intervals all overlap 1. So none of these were statistically significant as individual outcomes, but at least consistency of the benefit for all of these outcomes: cardiac death, MI, reinfarction, and heart failure. What's the downside? There was no increase in second degree or third degree AV block. And other sort of adverse events were not significantly different. And so the argument is that this is a safe thing to do for the majority of post-MI patients whose ejection fraction is between 40 and 49%, i.e. give them a beta blocker or continue on a beta blocker rather than not giving them a beta blocker or withdrawing a beta blocker. And this was published simultaneously in The Lancet. So just to revisit this before I open up for comments and questions, I've mentioned the Sweetheart Reduce AMI study, but they had an EF of 50% or more, and they saw no advantage of initiating versus not initiating a beta blocker. The Abyss study, although not statistically significant, showed some potential harm of withdrawing beta blockers remote from the myocardial infarction. The Reboot study showed no difference, but the Baitami-Danblock study showed an overall benefit, a lower risk of death or major adverse cardiovascular events with beta blockers. And this was teased out further in the meta-analysis, where the biggest bang for the buck is in those whose EF is 40 to 49%. So I think to the question, should we continue beta blockers or initiate beta blockers in the peri-MI and post-MI patient population, I think it's an absolute yes if the ejection fraction is below 50%. Maybe not if the EF is 50% or above, but based on the totality of the previous information and these trials, I would argue we should give beta blockers, and then one could revisit that at 6 to 12 months' time, and then if the EF is 50% or more, you may decide informed decision-making with the patient with all the other secondary prevention therapies to drop beta blocker at that point. Okay, so let me stop sharing again here and open up to comments or questions that you might have related to that series of beta blocker studies. And anybody's comment on my take of the, yes, we should probably continue beta blocker therapies in all post-MI patients, but at least those whose EF is between 40 and 49%. Lots of thumbs up. All right. So just so that I can grab the one other area that I think is important, although there are many to cover, let me share my screen again here. Sorry. I'm a non-interventional cardiologist. Apologies for the technical difficulties here. All right, let's go back here. All right, so the last topic is should patients, hopefully you can see that now, should patients who have both coronary artery disease and atrial fibrillation who need stroke prevention with oral anticoagulation in atrial fib, should they continue to receive antiplatelet therapy, which has been our go-to, like aspirin, like P2Y12 receptor inhibitors? Should they continue to receive dual antithrombotic therapy? These are earlier trials that were done. The OAC alone study wasn't powered. It was stopped early, but numerically suggested that there was no difference between, in red, those who received an oral anticoagulant alone, who had concomitant coronary disease and atrial fibrillation, and those in blue who received both oral anticoagulation and a single antiplatelet therapy, mainly aspirin. Out to about 2.5 to 3 years' time. In contrast, on the right-hand side, you'll recall in 2019, the Japanese investigators' study FIRE was stopped prematurely on the recommendation of the Data Safety Monitoring Committee because the combination therapy, in this case, the OAC, the oral anticoagulant, was rivaroxaban together with antiplatelet therapy, single antiplatelet therapy. Those individuals actually had more adverse events and more bleeding, understandably, compared to the rivaroxaban monotherapy group, where aspirin or other antiplatelet therapies were dropped. And then I presented out of this was the ESC from last year when I shared these findings, the EPIC-CAD study with edoxaban together with single antiplatelet therapy compared to edoxaban monotherapy alone showed a net clinical benefit in favor, again, of monotherapy. Of course, this was mainly driven by the increase in bleeding that was experienced by the patients assigned to dual antithrombotic therapy. So not surprising at all when you look at the net clinical benefit, although the event rate for ischemic events, including ischemic stroke and mortality, very low in absolute terms. So it still raises the question, yes, there's less bleeding if you drop an antiplatelet therapy and just go with oral anticoagulation therapy alone, but is there a price to pay from, let's say, a coronary artery disease perspective, recurrent ischemic events? And so the French investigators attempted to answer this question with the Aquatic trial. And this was, I love the title, Aquatic is Assessment of Quitting versus Using Aspirin Therapy in Patients with Stabilized Coronary Artery Disease after stenting who required long-term oral anticoagulation. You're already aware of the background. All the trials previously showed that I showed you were open label. This is a double-blind study. They enrolled lower risk patients. They didn't focus specifically on exclusively on the stented patient population, who often need some duration of dual antithrombotic therapy, including dual antiplatelet therapy. And all the previous trials were uniquely targeting Asian patient population, and so there may be some variable responses to antiplatelet and bleeding risk, etc. And so the French investigators did the Aquatic study. This is the design paper, and you can see that they had the randomization was stratified according to whether patients were currently receiving oral anticoagulation and single antiplatelet therapy like aspirin or not. These are all patients who are on oral anticoagulation, plus or minus single antiplatelet therapy, who were at least 6 months remote from their stent implanted for their underlying coronary artery disease, and they had to be at high atherothrombotic risk, defined, for example, as patients who had a PCI 6 months ago or more because they had an ACS, or they had diabetes, chronic kidney disease, polyvascular disease, prior stent thrombosis, etc. Now, the trial was stopped prematurely on the recommendation of the Data Safety Monitoring Board after a median follow-up of just over 2 years because there was an excess all-cause mortality in one of the randomized treatment groups. And so these are the final results, which is the primary efficacy outcome: cardiovascular death, MI, stroke, systemic embolism, any coronary revascularization, and acute limb ischemia. So remember, again, this contrasts with the primary outcome of the previous studies that I showed you, where the primary outcome was these types of ischemic events, but also major and clinically relevant non-major bleeding. So bleeding drove the benefit in all the other primary outcome findings in the previous trials, where here their primary efficacy outcome is exclusively ischemic events, including cardiovascular mortality. And there's a clear benefit in red here to the placebo group, i.e. those who just received oral anticoagulation, compared to those who continued in a double-blind fashion on not only oral anticoagulation, but also aspirin therapy. Unsurprisingly, there is more bleeding on dual antithrombotic therapy compared to single monotherapy with oral anticoagulation alone and dropping aspirin. But here is the mortality difference. So there was actually an increased mortality in those who were receiving dual antithrombotic therapy. And here is the difference in atherothrombotic events. Really, overall, no significant differences in the individual components of the atherothrombotic adverse events. And so Aquatic is the first double-blind placebo-controlled trial, and it showed that adding aspirin to oral anticoagulation or continuing on aspirin together with oral anticoagulation significantly increases not only the risk of major bleeding, but all-cause mortality and ischemic events. Now, this might seem counterintuitive. How could cardiovascular mortality, MI, stroke, systemic embolism, etc., how could that be more frequent in patients where aspirin is dropped and there's only monotherapy with oral anticoagulation therapy? And this was simultaneously published in the New England Journal of Medicine, but I think it reminds us that thrombosis is often a consequence of bleeding. In other words, when somebody has a major bleeding episode, you have to stop often all of your antithrombotic therapy, including aspirin, including antiplatelet therapy. And it takes a while before those individuals get back onto treatment. And so bleeding, you could argue, of course, can lead to fatal events. But in this particular case, what's probably happening is there's either minor bleeding and the patient is stopping because they had their third nosebleed in 24 hours, or because they're on aspirin and oral anticoagulation, or they're having a major bleeding episode and the therapy gets stopped, and then the consequences of the bleeding actually is an increase over the course in time in cardiovascular ischemic events, including cardiovascular mortality. So this isn't just because people are bleeding more to death, it's the consequences of bleeding that then lead to ischemic events down the road. So thrombosis is bad, but so is bleeding. And so we want to use a minimum duration of dual antithrombotic therapy. And these findings really support from Aquatic the Canadian Cardiovascular Society guideline recommendations that say you should really only as an exception, they say beyond 1 year's time, but only as an exception be using a combination of oral anticoagulation therapy and atrial fibrillation with any antiplatelet therapy. In other words, monotherapy with oral anticoagulation therapy is also effective at preventing ischemic events in patients who have concomitant coronary artery disease. Okay, so we're 1 minute over, and I do want comments or questions on this aspect, so I'll skip over the 3 trials in terms of the summary and stop sharing and offer anybody the opportunity to comment on the Aquatic trial and the continuation versus discontinuation of aspirin. And please go out and look in your patient population. I've done this. We have lots of our patients who have atrial fibrillation and concomitant coronary artery disease, and a lot of them are on both an oral anticoagulant and an antiplatelet. And that is a harmful strategy in these patients. So please go through your patient practice and look and see whether there's a really compelling argument to continue antiplatelet therapy or aspirin in these patients. Any comments, questions? Thanks, Farzad. All right. I don't see anything in the chat. Thanks, Kim. Hope that was of help to you. Again, the takeaways are, at least in ICD patients, you want to aim for a potassium between 4.5 and 5. That's going to make a difference on arrhythmias and clinical outcomes. In individuals who are post-MI, I think you should be giving them a beta blocker, even if their EFs are only minimally reduced. And those who have concomitant coronary artery disease and atrial fibrillation, once they're at least a month, 3 months, 6 months, whenever you feel it's appropriate, they should come off of all of their antiplatelet therapies and just go on, stay on an oral anticoagulant for both stroke prevention and ischemic complications of underlying coronary artery disease. Hope that was of help to everybody. Thanks so much.